Well, good morning, everybody. This event this morning makes me even more proud than usual to be a member of the board of the New England Council. Taking on this very important issue on a regional basis shows us the importance of what the New England Council does in bringing us all together in the New England region to deal with problems that we cannot deal with state by state or company by company. So it's a real pleasure to be here with you this morning. It's also a pleasure to see in the audience, sitting over here at our Tufts Health Plan table, the president of the Massachusetts AFL-CIO, Steve Tolman, a longtime leader in addiction, the fight against addiction. Steve is also a member of the board of the Tufts Health Plan Foundation and provides us with a very important perspective on this issue. We have a very distinguished panel here this morning. We've heard some powerful remarks from Senator Markey with a great deal of information about how serious this crisis is, and very important leadership from Governor Hassan. Now we're going to hear from private sector leaders close to the front lines on dealing with this issue. You have their extensive biographies, so I'm not going to go completely through them, but I just want to welcome Dr. Stephen Benson, just to my left here, the Regional Medical Director for Beacon Health Options, Tom Davis, Vice President of Pharmacy Professional Services for CVS Health, Dr. Dennis Dimitri, President of the Massachusetts Medical Society and Clinical Associate Professor and Vice Chair of the Department of Family Medicine and Community Health at both UMass Memorial Medical Center and UMass Medical School, Dr. Tony Dodek, longtime friend, Vice President of Medical Quality and Strategy and Associate Chief Medical Officer of Blue Cross Blue Shield of Massachusetts, Don Herder, Global Head of AIG Medical Management Services, and Christopher Walsh, Director of the Special Investigations Unit at Harvard Pilgrim Healthcare. I'm going to begin by asking each of our panelists a question or two, then we'll come back to some general questions for the panel altogether. And I'm going to begin with Dr. Benson. I hope many of you have picked up the Beacon Health white paper on the crisis of opioid addiction. And it asserts that because addiction is a brain disease, it should be treated using a chronic disease model of care, also known as chronic disease management, similar to how we treat individuals with diabetes or asthma. Doctor, would you briefly describe the chronic disease model of care and what are the implications of that model for employers?
Sure.
Let's make sure that microphone is on.
Is this microphone on?
Yeah, now I think it is.
Okay. No, I really appreciate being here and appreciate the opportunity to explain our chronic care model for addiction treatment. I think one of the first real hallmarks of a chronic care model is the acceptance of addiction as an illness. We heard Senator Markey refer to the stigmatization of addiction treatment. And I feel that one of the positive things of this horrible crisis is the growing acceptance of addiction treatment as an illness, but moreover as an illness that is treatable with chronic care disease interventions. One of the key things with developing a chronic care model is to really shift healthcare treatment models from an acute care episodic model that is kind of an inpatient detox, residential, facility-based model, to a long-term episode of care treatment model. And we are working at various payment reform strategies to help move providers to treat people through the chronic nature of the illness. Opiate addiction is not something that is treated and cured with an intensive residential detox admission. We really need chronic long-term care to prevent relapse, prevent reoccurrence, and we need chronic long-term care to repair issues that have occurred in the person's environment, home, workplace, and social settings. And these kind of things can keep people well. Also, we're pushing self-management supports, and part of that is moving providers to inform members and inform people seeking treatment of the treatment modalities available. Unfortunately, because the addiction provider system has been essentially outside the medical system for a number of years until mental health parity in 2014, addiction treatment providers really worked independent and separate from the medical community. And they developed kind of an apprentice type model, and a lot of facilities really have one way of kind of treating the illness. We are working and partnering with these facilities to really open up different modalities of treatment, and that includes also the use of medication-assisted therapy, which is profoundly helpful for members with opiate treatment. And unfortunately, we still have some providers who do not inform people seeking addiction treatment, especially opiate treatment, of the availability of medication-assisted treatment, or we have providers that are still tied into an abstinence-only model. And that is one of our efforts, and we've been very successful with that over the past year, especially with what has happened politically and what has happened in this country as far as messaging the crisis of opiate treatment and the need for appropriate treatment.
Doctor, would you just explain a little bit more about what medication-assisted therapy means?
Medication-assisted therapy are medications that can be used, such as Suboxone, buprenorphine, methadone, Vivitrol, naltrexone, which actually, methadone and buprenorphine suppress the craving to use the drug. And we call them medication-assisted therapies because what they do is if you can eliminate the craving, the desire to use, the desire to get another drug, the desire to break into a house to steal something, we can engage people in treatments that can improve their long-term outcomes and long-term maintenance of employment. We find, too, that medication-assisted therapies are very effective in treating people in a confidential manner. When medication-assisted therapies were initially available, one of the caveats of Suboxone treatment is that people could receive treatment at home in their community and did not have to go away to an inpatient facility. And also people in the commercial space, especially management level people, because as we said, this affects all kind of stratas of society, could actually receive detoxification, induction of medications, and continue their job, continue their role in their family, and continue their role in society without disclosing to someone else they have a problem. And medication-assisted therapies have helped countless people on the commercial space and that are employed. And we're really actively pushing to increase the number of providers. Through our EAP services, we have noticed an uptick over the past year that we have people calling, trying to find treatment with Suboxone, but there are no providers available in their community. So we're actively working to really increase the number of people that can prescribe Suboxone or buprenorphine. Also, we embrace a continuum of services within the chronic disease model. ASAM is our medical necessity criteria, which is the Association of Addiction Medicine that has put forth continuum of care model. And there are 10 different continuums, 10 different levels of care for addiction treatment. So we really support members engaging treatment at whatever levels are appropriate for their needs. And we are messaging that to providers, and as well as through our EAP services. People can engage treatment at multiple levels and also need to step down through multiple levels of care, typically during their course of the illness. And we have been actively putting those systems together. We also feel the chronic disease model really needs to emphasize decision supports. And one of the issues about addiction treatment being sort of outside, I use the term body medicine before parity, is that if a provider identifies somebody with an addictive problem or opiate dependence, don't readily know how to access people in treatment. So we are really engaging with the primary care community as well as other medical providers to really let them know where to call, how to access treatment for members that are overusing and taking opiate medications, because that is one of the issues. We don't want providers to just stop the opiate, because then we have people shifting over to the heroin use that was discussed previously. But what we want is to engage people in treatment, and that has been problematic from a provider standpoint because they really haven't been able to make those connections. Finally, we feel that information support is really key in a chronic disease model, and unfortunately we have very little long-term outcome study for addiction treatment, and we are partnering with providers to formalize outcome models for their treatment programs. We also feel there should be a database for outcomes on medication-assisted treatment. We do know, however, that medication-assisted treatment profoundly affects the overdose rate. People that take medications for opiate treatment, the overdose fatality rate is significantly improved with the use of medications. And I finally would like to touch on the use of employee assistant services. We integrate EAP services with our utilization review process when appropriate, and we find that employer-based referrals can be very helpful in engaging members, but we really need to message, I think, more to members that these services are confidential. We still have members that sometimes are resistant to call their EAP service for fear that their call will be disclosed to their employer. We also have significant uptick in family members calling. So family members really need to know where to turn for treatment. And we know that the consumers, over half of them feel that addiction treatment should not be done within the medical system. We really need to push that a physician needs to be overseeing addiction treatment and needs to be part of the involvement in care. And we hope once that shift occurs, we have more patients kind of actually seeking treatment either through EAP or directly with other providers. Because through EAP, we can make physician appointments and make linkages. And so we feel EAP is a very good gateway to kind of move people into the treatment paradigm and to message kind of what is needed for appropriate treatment.